day ahead. Hope you are fresh enough, and apologize for the crowded sessions that we'll have, but because of the paucity of time, we have to do that. So we have kept coffee round the clock. Any of you feeling sleepy, please go ahead and have a cup of coffee. So Dr. Ganeshan was asking why ASCO update, what is that? AJCC update as the first session.
It's
so
okay.
we have the most smart faculty and the youngest superstar for us as the first session. Dr. Mani is a very close friend, and he's going to take us through the AJCC 8th edition, what you should know. This is slightly controversial because invariably in the exam somewhere they'll touch upon this because it's a huge change from the previous edition. Some of the examiners may not be aware, as many of us may not be aware of the changes compared to you which you are fresh. So Mani will give you an overview on what are the things you should watch out for, and in some of the case discussions like breast, lung, ovary, some changes you might need to tell the examiners if they ask. And as I always tell, don't argue about the AJCC 8th and 7th. Finally, it's the same because as again Professor Ganeshan was mentioning, all the clinical trials which we follow now, till now has been done in the 90s and 2000, where we have the previous AJCC edition. So all the clinical decisions may not immediately change with the new staging system. So you have a balance on how you are going to deal with during the exam, and we hope Mani will be able to clear some of the doubts that we have about new AJCC. Mani, please.
They have mics. Yeah. So good morning all. At the outset, I would like to congratulate Dr. Rajiv for this wonderful initiative, this masterclass in oncology. He has been the brainchild behind the COPE, that is the practical questions related to oncology. And today I'm here to speak about AJCC 8th edition, what you need to know. Warm greetings from Cancer Institute, Chennai. Yeah, so the first edition, the AJCC with a combination with TNM came in 1977. So the main aim why this initiative came was there should be to compare different groups of cancer, and this should help in assisting the prognosis and treatment, and the state of cancer should be communicated among the different oncologists. So we here are with the 8th edition, wherein the objective has changed from more population-based approach to a more personalized approach. So we see the AJCC gets revised once in 6 to 8 years, and from the 6th edition onwards, we have various non-anatomic factors have been incorporated. Apart from the routine TNM staging, we have various factors which are incorporated. And this edition is valid from Jan 2017. And in this edition, we have close to 12 new stagings which has been incorporated. So some of the new classifications which have come in the AJCC 8th edition are the HPV positive oropharyngeal cancers. We have separate classification for the carcinoma of the unknown primary. For the thymic cancers, we have separate classification, neuroendocrine cancers, sarcomas, both bone and soft tissue. So this we would know when we would use the prefix of Y and C, that indicates something has been given in the neoadjuvant setting. That could be either chemotherapy or radiation. And when you do a clinical stage, it is YC TNM. And in case a surgery has been, surgery is done post neoadjuvant therapy, that could be either neoadjuvant radiation or chemotherapy. That should be documented as YP. And for patients who have recurrent tumors or relapsed tumors, we should prefix them with a small r. And if a patient is diagnosed with cancer at the time postpartum, it should be prefixed with A. So pathologic staging should include comprehensive that in detail about the clinical staging. We should know about the surgical intraoperative notes and the pathological specimen. So the AJCC 8th edition clearly mentions the final pathological stage should be done by the treating oncologist. It should not be by the pathologist. It should be done by the treating oncologist. That could be a surgical, medical, or a radiation oncologist. So here, I'm not here to tell in detail about stage 1, 2, 3, all the minute details I would not be able to tell. This is just a broad snapshot view of what we should know in terms of changes which has happened from the prior staging. So I would be covering the common cases which actually comes as the exam cases, mostly the practical cases, lung, breast, head and neck, and the ovary. For the lung cancer, The AJCC one advantage, if you read the staging, is it not only mentions about the stage, it also gives you a broad view about the overall prognosis, what are the investigations that has to be done. For advanced stage lung, apart from a PET-CT, it also recommends it for an MRI brain. So this we know because brain PET is not a very sensitive investigation to assess the brain. Many a times small subcentimetric lesions could be actually missed in a PET-CT, and so a combined MRI and a PET could be done. For a small cell lung cancer, traditionally we use the veterans staging. We classify them as either limited or extensive small cell. So suppose you take a limited small cell, you give a 5-year survival of around 30 to 40%. Actually, there can be a huge variation. If you say a small cell of stage 1A, the survival can be as good as 93%. And for a stage 3C small cell, the survival can be as low as 19%. So the present AJCC 8th edition says, even for a small cell, it is preferable to use a TNM stage for us to more accurately determine in terms of prognosis. With regards to the T staging, there has been some key changes. So prior we had to remember only two numbers, 3 and 7. Anything less than 3 was T1, 3 to 7 was T2, and more than 7 was T3. So here you have to remember 3, 5, and 7. Any tumor less than 3 cm is T1, 3 to 5 is T2, 5 to 7 is T3, and more than 7 cm becomes T4. With regards to the T staging in detail, I've just documented the red ones are the key changes that has happened from the 7th edition. So prior we had any endobronchial growth. Prior you had less than 2 cm from the carina or more than 2 cm from carina. So here the present one without involvement of carina becomes T2. If a patient with endobronchial growth has carinal involvement, which may actually necessitate a lobectomy, so this would actually come under the T4. The second change is with regards to atelectasis, that is collapse of the lung. So the prior staging said that partial atelectasis was T2, complete atelectasis is T3. So here the new one classifies as any atelectasis, irrespective of being partial or complete, is actually T2. Mediastinal pleura has been removed from the staging, and also diaphragm, initially it was in the T3, that has been brought down to the T4. And this is one of the common questions where examiners would ask if a patient with lung cancer has got phrenic nerve involvement, it is actually T3 stage, and if a patient with lung cancer has got recurrent laryngeal nerve, it actually becomes T4. And one more question which examiners are fond of is, you have a separate tumor nodule. So if a patient has got a separate tumor nodule in the same lobe of the same side, it is actually T3. If there is a nodule is there in a different lobe on the same side of the lung, it is actually T4. And if the tumor nodule is in the contralateral lung, it becomes metastatic. It becomes actually M1. And the prior staging did not include stage 3C. So in the present edition, you have stage 3C. So T3 and 3 and T4 and 3 have been included in the 3C. With regards to the M, there has been a slight split. So prior we had only M1A. So here M1A is any tumor nodule in the contralateral lobe, which I just mentioned, pleural or pericardial nodule, or malignant pleural or pericardial effusion. Also, if a patient has got a single extrathoracic site of Mets, that has been classified as M1B. The reason they say many times this should be considered as an oligometastasis, and the intent can be actually curative intent. That has been separately classified. And of course, extensive multi-organ involvement actually becomes M1C. Then we move on to the breast cancer staging system. The lobular cancer in situ has been removed out. So this is more like a benign entity, henceforth it is not considered as part of a cancer. And various genomic tests, be it Oncotype DX, the MammaPrint, PAM50, EndoPredict, has been incorporated into the staging system. With regards to the level of evidence, they say Oncotype DX is actually level 1 evidence. So this we all know, the most recent. So prior, the Oncotype DX low risk, we were quite convinced that we can avoid chemotherapy based on the recent presentation in ASCO, and it's been published in New England Journal of Medicine. We also know even in the intermediate risk, many women actually can be spared from giving chemotherapy. So if a patient has got a tumor, multifocal tumor, that is there are multiple tumors, say 3 cm, 2 cm, 2 cm, we should not add up all the tumors. Multifocal tumor should be only the largest tumor should be given in the multifocal site. And we know T4B, clinical T4B includes any ulceration or satellite nodule or pudgy orange. So in case pathologically, if you find the tumor infiltrates the dermal lymphatics, you should not classify that as a T4B. You should always go with the clinical stage. And post-neoadjuvant therapy, the largest size of the residual tumor should be documented. We should not document any treatment-related changes or necrosis should not come under the staging system. So this is the T1 tumor. So the T1 is any tumor less than 2 centimeter. So here you have a less than 5 millimeters, that is T1A, 5 to 10 millimeter is T1B, and 1 to 2 centimeter becomes T1C. Any tumor size 2 to 5 centimeter becomes actually T2 tumor, and T3 is more than 5 centimeters T3. And here you have various examples of T4. So T4A is actually a tumor infiltrating the chest wall. The chest wall includes ribs, intercostal muscle, and the serratus anterior. And T4B could be either a satellite nodule or an ulceration or a pudy orange. And T4C is usually a combination of T4A and a T4B. And T4D, we know it is inflammatory breast cancer, any erythema or edema, more than a third of a breast, which has occurred within the last 6 months duration. And regarding the end staging, you have ipsilateral mobile nodes, it is N1 disease. If you have ipsilateral fixer or matted nodes, it is actually N2 disease. N2, and N2B could be if a patient has got both ipsilateral axillary nodes and internal mammary nodes. And how do we find what is the optimal investigation to assess the internal mammary node? Any of you? Yeah, CT chest would be the optimal investigation. N3A, you have the infraclavicular ipsilateral is N3A. N3B is again a combination of both ipsilateral axillary nodes and the internal mammary nodes. N3C is actually the ipsilateral supraclavicular lymph nodes. So this was the traditional staging, the anatomic staging, which we all had to remember for our exams. So there has been one major change which has occurred in the AJCC 8th edition, wherein they say apart from anatomic stage, we also have something called a prognostic stage. So this prognostic stage would include, apart from T, N, and M, we have to know what is the grade of the tumor, what is the ER, PR, and the HER2/neu. And even Oncotype DX also has been incorporated into the prognostic stage, and they say if in case you have all the available information, including the T, N, M, the grade of the tumor, and the prognostic, that is ER, PR, and HER2/neu, the preferred staging would be actually the prognostic stage. So this is an exhaustive stage. I'm sure even the editor of the breast AJCC would not be able to remember unless he actually goes through it. So here if you see traditionally T3N2, so what stage would it be? T3N2 would be what stage? Yeah, it should be a 3. So if a patient with T3N2 and the patient does not have grade 3, this grade 1 or 2, and the receptors could be positive, so essentially the stage is actually 1B. So it adds so much confusion. So there is a lot of asterisks in that. So the prognostic stage should be given only if the patient is able to receive the optimal adjuvant therapy. Suppose if the patient is HER2 positive, he should receive the complete, say, 1-year adjuvant trastuzumab, received anthracycline taxane. In case you are not able to give the optimal adjuvant therapy, you should probably stick on to the anatomic staging, TNM. So the AJCC actually concludes by telling we have to include both stagings, the anatomic staging, TNM, as well as the prognostic stage. And at recurrence, it's always preferable to have biopsy, all accessible sites. Even though you can have an early recurrence, you're quite sure. Quite often we have found surprises, it suddenly is tuberculosis or it's some different cancer, papillary thyroid. So biopsy confirmation from all accessible sites is recommended. And it is of paramount importance that we test the receptor status in the biopsy specimen. There could be always a possibility that a receptor positive could be receptor negative could be actually changed to positive subset. Moving on to the next subset, the head and neck cancer. So one of the key things in AJCC present, it doesn't cover only the staging system. There is a lot of information about the survival curves, pathology. So I would recommend, at least for the exam cases, that is the ovary, breast, head and neck, at least you read once the AJCC, so it gives a comprehensive idea about the management of the cases. So you see a stage 1, 2, 3, 4, there is a huge split in the curves. So they actually had a comparison with the prior stage. The curves were actually intermingling. So with all the various factors incorporated, they find huge separation of the curves. And in head and neck, one of the key components that has been added is the extranodal extension. So they prefer that we should not use other terms like extranodal spread or perinodal spread or perinodal extension. We use ENE as the form. And this is used only in the HPV unrelated cancers. And if any patient has got extranodal extension, straight away, actually the nodal stages would become N3B. So that could be a clinical N3 as well as a pathological N3. Clinical N3 is if the patient has got lymph nodes which infiltrates the skin, musculature, or the underlying structures including the cranial nerves, brachial plexus, sympathetic trunk, or phrenic nerve invasion. And we also could have a pathological extranodal extension, that is, if the tumor extends beyond the lymph node capsule to involve the surrounding stromal tissues, it becomes pathological extranodal extension. Even I got this image from the AJCC. So here, this is the lymph node. You have tumor infiltration of around 3.8 millimeter into the adjacent structure. So this is pathological extranodal extension. Here again, this is a magnified view. These are the tumors. This is a normal fat tissue. The tumors are infiltrating the adjacent fat tissue. This is again a pathological extranodal extension. This we know all the levels of cervical lymph nodes. 1A is submental, 1B is submandibular, 2, 3, and 4 are upper, middle, and deep lower jugular. 5 is the posterior cervical, 6 is the paratracheal, and 7th is the upper mediastinal lymph node areas. If a patient has got carcinoma of unknown primary, we have to test for HPV status. If patient is HPV positive, we have to stage them as per the oropharynx. We also have to test them for EBV. If it is positive, we have to stage them as per the nasopharyngeal cancers. So this is the oral cavity cancers. So every stage you have the ENE, there is the extranodal extension. And if the patient has got extranodal extension, straight away they are upstaged to N3B. So we all know that HPV positive cancers have totally a different subset. They are younger patients, more healthier. They don't have exposure to tobacco. They could be either HPV 16 or 18 positive. And they say IHC P16 is a very good surrogate endpoint. I know Dr. Ganeshan would not agree with that. So based on some retrospective studies which are published in 2012, they say IHC P16 is a good surrogate marker for HPV positivity. And they also have a very good prognosis as compared to the HPV negative tumors. So this is the new staging system in the HPV positive cancers. 1, 2, and 3 are similar. Stage 4, in general, all the head and neck cancers have either moderately advanced or very advanced. So stage 4, they classify moderately advanced as T4A. Although they are advanced, many of them are operable. T4B is essentially the inoperable tumors. For the HPV positive tumors, you don't have the separate split into T4A and T4B. So they just say T4. So that includes involvement of larynx, extrinsic muscles of the tongue, pterygoids, hard palate, and the hyoid. So any tumor less than 2 centimeter is T1, 2 to 4 centimeter is T2, more than 4 centimeter is T3, and T4 is infiltration of adjacent structures, which I just mentioned is actually T4. For the clinical N, you have N1, N2, and N3. There are no splits. N1 is ipsilateral lymph nodes level less than 6 centimeter. N2 is contralateral or bilateral lymph nodes which are less than 6 centimeter. And any lymph node more than 6 centimeter becomes N3. And in the pathological N, there is no N3. So N3, there is no N3 for the HPV positive oropharyngeal cancers. The number of involved lymph nodes less than 4 is actually N1, more than 4 is actually N2. Moving on to the last staging system. For the ovary, fallopian tube, and the primary peritoneal cancers, it has been all combined and put together. And the imaging preferred choice is the contrast CT of the abdomen and pelvis. MRI, they say it could help in assessing better in terms of the adnexal structures. So I would just tell you through the key changes. The stage 1C has been split into 1C1, 1C2, and the 1C3. 1C1 is the surgical spill, 1C2 is the capsule rupture before surgery, or it could be tumor on the ovary or fallopian tube surface. 1C3 could be either the malignant cells in the ascites or in the peritoneal washing. In stage 2 ovary cancers, the 2C has been eliminated. So they are basically extension to the 2A could be extension to the adjacent structures, which could be uterus, ovary, or the fallopian tube. To any other pelvic tissue extension is actually 2B. Stage 3 is split into 3A, B, and C. 3A is microscopic extrapelvic peritoneal involvement and or metastasis to the nodes, retroperitoneal, either paraortic or pelvic nodes. Any tumor mass less than 2 centimeter, which is macroscopic, and extrapelvic is actually 3B. And if you have macroscopic extrapelvic peritoneal mass more than 2 centimeter, it becomes 3C. And Stage 4, again, it has been classified into 4A and 4B. Pleural fluid, which is positive on cytology, is stage 4A, and 4B could be either liver or parenchymal metastasis. Capsular, subcapsular liver or spleen is still a stage 3C, and any extra-abdominal organ involvement, including the inguinal lymph nodes, becomes stage 4B. And also they mentioned transmural involvement of intestine, actually a stage 4C. This is not still a local disease. Any transmural involvement of the intestine would be upstaged as stage 4B. So I would like to conclude by telling that this is just a broad snapshot view of what are the key changes. So for you, the best way to remember any staging is if you have a cancer, if you have a patient, if you go back and read, and if you try to understand, that is the only way you can understand and remember it for a very long time. And at least because exams are on a very short period, at least common things, it would be very useful if you read at least the breast, ovary, head and neck, lung, and so on from the AJCC. Apart from the staging, it gives a lot of information in terms of the survival curves, the pathology examination, and the key changes. Thank you.
Thank you, Mani, for setting the stage for the day. So, few questions for the staging part. I think he made it quite clear what are the things to focus on. Questions, please. Anything on this, Mani? Now we have one more faculty, Dr. Nikita, who is with us today. And if you don't ask questions, she will be there with some questions now. So she'll have open queues with all the sessions that we are going to have. So you better keep her away by asking questions to us. Otherwise, we'll come back with questions to you. There are open queues which is going to happen, where we will have some questions on the sessions that are happening, so that there will be some interaction. Yes, Mukesh.
Can we get the idea why these changes were made? These are reasons for this.
So yeah, that's a very good question. Why we have to make changes? So this AJCC, every change happens every 6 to 8 years. So there is a big panel which goes through exhaust, like for lung cancer, if you they take all the ISLC data, prospective, retrospective database, try to correlate with various prognostic factors. So prior to AJCC, say 6th edition, it was only the T, N, and M. So there were a lot of factors like the GIST, you have the KST7 which is incorporated. In sarcomas, the grade has been incorporated. Now the breast, it's exhaustive. It includes the grade T, N, T, and the ER, PR, and HER2/neu. So basically, they try to understand what are the various other prognostic factors. So it should not be just an anatomic staging. We should we are moving to a personalized medicine wherein we want to incorporate all the changes. I'm sure Dr. Ganeshan would disagree with me. So that is the one key.
There is no P and T and 3 in head and neck. Why those changes? Like any particular reason they have cut down?
Yeah. That is one reason they say, one of the survival curves which I showed, wherein the survival curves were actually intermingling with each other. So here you have a separate subset. If the patient has got N3B, the prognosis is going to be extremely poor, irrespective of any other factor, irrespective of the tumor size, irrespective of the grade of the tumor, irrespective of the age of the patient. If the patient has got extranodal extension and head and neck cancers, the survival curve it is going to be extremely poor. So these factors, based on the multivariate analysis of the various studies, prospective and retrospective, if some factor is emerging as a poor prognostic factor, they would want to separate it out as a separate factor. Yeah. If you would like to add any.
Clearly made it. So basically, it's based on the outcome on the previous trials that has gone on. One very good example, as Mani was trying to tell, is the supraclavicular node in breast cancer. So it has gone C changes. It has metastatic to start with in 1998 and then came back to 3C. Why? Because there were 2 clinical trials which included the locally advanced breast cancer, the supraclavicular node. And they found that their outcome was equivalent to a patient who was stage 3. So that made the AJCC learn, and they changed the supraclavicular node from metastatic to a locally advanced or a N3. So that's how they will learn. So as Mani was rightly pointing out, now we have no meaning in saying that T1 N0 breast, because you can have a very triple negative, or you have high oncotype score. So they are not determining the outcome per se, if you just determine only the C, T, and N. So there are a lot of clinical trials, for example, the oncotype DXSA with the Taylor trial, which has shown us that if you incorporate that as a prognostic model, it is very clearly showing the outcome. So then the AJCC learns from it and appropriately include them in the staging, so that you know that a good prognostic stage 1, what is it? So we know that the ER/PR has been taken into account, grade has been taken into account, the prognostic models have been taken into account, so that all of us will speak the same language and say that, okay, what is the good prognostic breast, rather than purely say only T1. Sir, you want to add something?
No, nothing much. I think the key thing is basically how it relates to outcome, as you heard just now. A lot of the subdivisions are made based on a little over enthusiasm on the staging system. But nevertheless, they are important to actually point out. And more and more, I mean, in fact, the current cell, there are 10 papers on all the molecular basis of cancer across the board. So breast cancer is one example, but you will find that more and more cancers come with that. So the staging system, as we know it, will become redundant. This is only 10 years from now. From the science point of view, I know it now. But from a practical point of view, it will take another 10 years for it to come into the breast has already come. And you heard about ERPR positive. Even if it is not positive, if you have luminal A, effectively you are stage 1 in a postmenopausal woman. So you will be incorporating more factors. But essentially, I think it is very difficult to remember all the permutation combinations. And that's what I was discussing. In Amrita, we created the software along with the electronic system. So you just put the T, N, and M stage for any tumor. It will tell you what is the actual classification. So that, I think, somebody should take it up as a thing. So for all the residents and the future faculty, it will be very helpful to actually accurately stage.
And for some tumors, the tumor size, the T size doesn't matter. Like you have ovarian tumor, which could be 30 centimeter size or 1 centimeter. The prognosis doesn't change. All it matters whether there is any capsular infiltration. Same thing with colon cancer. Only it happens with whether submural, submucosal infiltration, so on.
Another important point is the staging is for us to speak the same language. For example, if I put stage 2A cancer in clinical trial, then across the world it should be the same. So that's a very important aspect of staging. We all speak the same language. So that especially in clinical trials, we get a uniformity. Otherwise, it becomes very varied. As he told, if somebody include perhaps 30 centimeter tumor ovary, and then somebody tells, no, I am putting only 2 centimeter. That's not there. So if you put, what is stage 1C ovary has been put across the trial, then we know we are all speaking the same language. So that's also very important when we design clinical trials, to have a good staging system.